My name is Hannah Afwerki, and this is my research project on combination analgesic therapies to treat dental pain. There are several analgesic therapies that are common after dental procedures, such as single non-opioids, combination non-opioids, combinations between opioids and non-opioids, and then also multiple opioids. Pain relief should be taken seriously. If not properly addressed, there can be several negative outcomes. Patients will be less likely to return to the dentist, and the dental office is less likely to perform new treatments. This will cause problems with getting prompt dental care or patients receiving the proper procedures needed, further resulting in decreased dental health. With the many analgesic options available, I'm wondering which one is the best. Best will be defined later in this presentation. Can pain be most effectively managed through using combination painkillers? Will two non-opioid medications or an opioid and a non-opioid be more effective than one non-opioid medication while still being safe? The typical therapy that I have observed in dental clinics is either a singular or a combination non-opioid. I hypothesize that a combination non-opioid therapy would be the most effective, inexpensive, and safe. Some benefits to non-opioid medications is that they are cheaper, have fewer side effects, and can still be very effective. However, just because there are usually fewer side effects with the use of non-opioids, the adverse effects should not be downplayed. Many of these are over-the-counter drugs that can have interactions with other prescriptions. Patients with history of ulcer, GI pain, irritation, or complications should use caution with or avoid NSAIDs. Selective NSAIDs, such as Celebrex, may be a good alternative for these patients. Non-opioids are very effective for pain relief. However, they may not be effective enough in certain circumstances. According to the research articles, the main benefit to opioid medications is the high level of analgesic effects. Most of these medications work on the mu-opioid receptor, which will distort the patient's perception of pain. This is a highly effective technique. However, this can cut into the patient's daily routine by making them drowsy or unable to perform adequately at school or work. With these strong analgesic effects come some intense adverse effects as well, such as nausea, vomiting, and upset stomach. I'd like to take a second to talk about tramadol. While it is classified as an opioid and still acts on the mu receptor, it does not use the same pathway of other opioids, making its effects weaker. This can make tramadol an ideal opioid, since it will have more intense analgesic effects than non-opioids, but result in decreased frequency and intensity of adverse events than other opioids. In an earlier slide, I stated that I wanted to determine the best analgesic therapy for dental patients. To define best, I want to find the therapy with the most effective analgesic effects, with the lowest frequency and intensity of adverse events. Efficacy has three areas that I assessed during my research: onset, intensity, and duration. Onset is defined by how quickly analgesic effects are felt, intensity is the strength of the analgesic effects, and duration is the length of the effects. The articles typically touched on one or two of these efficacy areas. Safety was assessed by intensity and frequency of adverse effects and toxicity. The balance between these factors will help determine which analgesic therapy is most appropriate. One common therapy for simple dental procedures is not a combination, but a single non-opioid, such as an NSAID or antipyretic. Patients with GI complications should be cautious when using NSAIDs, since these can result in ulcers and further GI irritation and discomfort. These patients should only take low-dose NSAIDs. However, for best pain relief, they may need higher doses, which will put them in danger of ulcers and further complications. As mentioned before, a selective NSAID may be the best option for patients at risk of developing an ulcer. A single non-opioid therapy has some benefits. It is cheap and easy to adhere to. However, may not have a strong enough analgesic effect in many cases. There seems to be conflicting results on whether these combinations are more effective or not. Many of the articles suggested that the analgesic effects were negligible or barely greater than 2 non-opioids, while others had conclusive evidence that a combination opioid-non-opioid was highly effective. What was consistent from the articles was an increase in adverse events. These are mainly sedation or upset stomach. The take-home message is that this therapy seems appropriate for moderate to severe pain, and that many researchers prefer tramadol as the opioid of choice. This combination had conflicting results. It will still work through separate pathways, as the 2 non-opioids do, but one of the pathways will be distorting how pain is perceived. This can cause undesirable adverse effects, which can be so intense that they disrupt the patient's daily routine. However, if pain is already disrupting the patient's daily routine, this may not be a big factor. There seems to be conflicting results on whether these combinations are more effective or not. Many of the articles suggested that the analgesic effects were negligible or barely greater than 2 non-opioids. However, Edwards, McKay, and Moore had conclusive evidence that a combination opioid-non-opioid was highly effective. What was consistent from the articles was an increase in adverse events. These are mainly sedation or upset stomach related, such as nausea and vomiting. The take-home message is that this therapy seems appropriate for moderate to severe pain, and that many researchers preferred tramadol as the opioid of choice. There was not a lot of data for combination opioids, only mentioned in 2 research articles. However, the analgesic effects seem to be high in both cases, even higher and with a more rapid onset when administered with a non-opioid. Adverse effects persisted. A significant increase in side effects was not noted in comparison with the opioid-non-opioid combination. This therapy was suggested for severe pain only in 1 research article. Once I concluded my research, it seemed as if my original hypothesis was too vague. I should have specified the level of pain the patient was in. I could argue that after most dental procedures, pain levels are moderate, but this is obviously not always the case. It is very important to assess the level of pain in order to administer the correct therapy. My hypothesis was supported for mild to moderate pain. However, patients may have more intense pain in which a combination opioid-non-opioid should be administered, or maybe even very severe pain in which 2 opioids and a non-opioid may be a good choice of therapy. It is important to assess whether the benefits outweigh the adverse events for each patient. Another important detail I pulled out of my research was that a non-opioid, such as ibuprofen or Celebrex, always seemed to help the efficacy of the analgesic effect. with adding little to no adverse events. Further research in this area can be difficult simply because pain is such a subjective symptom. It would be beneficial to collect more conclusive data on efficacy of non-opioid medications. Also, if an opioid with fewer side effects, possibly a more selective medication, could be created, this would also be very helpful. This concludes my presentation, and here are a list of the resources that help support my hypothesis. And here are a list of resources that contradict my hypothesis. Thanks for listening.